Hi everyone, welcome back to Emergency Chaos, where we talk about tips and tricks for new grads going into the ER. So today we will be talking about how to give report as an ER nurse. The first thing we have to keep in mind is who are we giving report to? Is it going to be a fellow ER nurse? Well, a lot of us are laid back, but because you're new and you don't perhaps know how each of your fellow ER nurses likes to get report, you're going to give a thorough report, and then little by little you'll figure out who likes a thorough report and who likes it to be super quick and super simple. But there are plenty of ER nurses out there who do like to get a very thorough report on their patients, and that's absolutely fair as well. If you're going to be giving report to the ICU or a telefloor, usually a more thorough report is going to be required, or at least you should be waiting or anticipating many questions at the end of the report. And then giving report to med surg, I've found it to be a hit or miss with like super thorough reports or super simple, what is the patient here for, what's pending type of thing. And then at the end, don't forget that it's always okay to say, hey, I'm new, so if I miss anything, just let me know, and if you have any tips, just let me know. I welcome them. Something simple. This will relax you, and then also let the other nurse know that you're new and not to be such a harsh critic on you. So let's go now into talking about actually giving report. So a quick report still has all of the essentials. These include, as I listed them, the name and the age of the patient, the chief complaint, the history, the allergies, and what's pending and what the plan is for the patient. So as far as the plan is the patient going to be admitted? Is the patient going to be discharged, or are they still pending a plan? Like the patient is stable for the time being, but the providers still haven't came up with the plan for the patient, or pending the dispo. That's another way of saying it. And the dispo or disposition essentially just means what's going to happen to the patient, what the plan is, So when they say dispo, it just means the plan for the patient. So now for a more thorough report, we are still essentially going to be doing and talking about everything we talked about already, but we're also going to be including things like associated symptoms, what was done for the patient in the ER, talking about pertinent labs, and we don't mean like every single lab, but we just mean the important ones. So for example, if a patient came in for like chest pain, then you have to mention things like the troponins, right? Or were they negative or were they positive? So pertinent labs to why the patient came in, and if they were out of the ordinary, right? So if they weren't normal, then you should mention it. So, and then after mentioning labs, we'll go into IV sites, their gauge, and if any medications are currently infusing. You also want to give a recent assessment of your patient. So giving the last vital signs, and then mentioning if they're ANO times 4, GCS 15, mentioning the respiratory status, if they're on oxygen, which is going to be included in your vital signs, right? But you can even say something like patient is ANO times 4, GCS 15, respirations or even in a labored, vital signs were stable at this time. And then you do want to mention if you gave any medications that alter mentation. For example, if you give a benzo, you should tell them, hey, we give a benzo and the time that you gave it. So if you give report to another nurse or you take the patient upstairs and the patient appears a little drowsy or a little altered, well, they're aware that you gave something, you give a medication that will explain why the patient is acting a certain way. So, and then you also want to mention things like if the patient has a Foley, if the patient has an NG tube, a chest tube, ostomies, wounds, a dialysis fistula, if they have a pacer or a defibrillator, and things even like like an amputation, if the patient has an amputation. And if the patient is NPO, please definitely mention him and tell him the reason for why your patient is NPO. And then if the patient is in a more critical state, you should be talking about which pressors the patient is on and the rate. If the patient is intubated, talk about the size of the tube, the length of the tube, the vent settings, and if the patient is tolerating the vent settings well. Mention if the sedation, mention which sedation the patient is on and how they're tolerating it. Does propofol need to be switched to Versed? for blood pressure reasons, or patient just is requiring more and more. Do they need to throw in a pressor for the propofol? If the patient's on BiPAP, talk about the BiPAP settings, and if they're tolerating the mask. A lot of patients don't tolerate the mask and just want to take off the mask, so you need to talk about things like that so that the nurse that you're giving a report to is aware of the situation as far as what's going on with the patient. And if the patient has a central line, mention like the location, the type of the central line. So as you can see, there's different types of reports, right? And although both include the essentials, one can be quick and concise while the other goes into pretty much everything, right? So you can do quick and concise depending on who you're giving a report to, or go into more thorough. And if you can always just do quick and concise for all of them and then just let the other nurse ask all the questions, right? So you kind of have to see who wants what. So here's an example of a similar report I've given in the past to a telenurse after my patient got admitted. And then on the next slide, I have the same report I would have given to a fellow ER nurse, or a more simple report, right? So the report is going to be a 49-year-old female doje came into the ER via ambulance with the chief complaint of worsening chest pain and shortness of breath for 1 week. The patient also endorsed increasing weakness and dizziness with occasional cough and difficulty sleeping lying down. Patient has a history of diabetes type 2, high blood pressure, hypothyroidism, and endorses chronic history of meth use. Patient denies any allergies. The patient on arrival was placed on BiPAP and started on a nitro drip. Has since then been weaned off the nitro drip and the BiPAP. Patient is currently on 2 liters via nasal cannula with an SpO2 of 95%. So, and then as far as labs, primarily the BNP is at 65,000. Other labs are pretty much unremarkable. Only things pending for the patient are an echocardiogram, and that's pretty much it. The plan for the patient is to admit to tele for CHF exacerbation, and then the patient has bilateral 18 gauges to the ACs. Since the patient arrived, the patient has had approximately 1,500 ml of urine output and is able to use the urinal without any assistance. The last vital signs were 95% on 2 liters nasal cannula, a blood pressure of 156/98, heart rate 99, respirations are at around 24, temperature of 98.9, oral, and the patient is speaking in complete clear sentences, and is anal ×4, GCS 15. So now, though, if the patient was more critical and perhaps was still on the BiPAP and the nitroglycerin drips, I'd mention what the settings on the BiPAP were, and if the patient was tolerating the mask. As well, I would go more in depth about the current respiratory status, right, and the cardiovascular status, giving details about the current respiratory effort and lung sounds. Do they still sound wet? Are they still having use of accessory muscles? Do they tripod at times? How is their mentation? Or is their mentation good enough to be on the mask? Because, you know, if they're on the mask, they have to be able to protect their own airway, because if they get super drowsy and they pass out and they vomit and they have the mask on and they're not awake enough to take the mask off, then that's another issue, right? So giving those that type of information, that type of details for patients who are more sick. And then I would also talk about where the nitroglycerin was infusing to, and the rate at which the nitroglycerin drip was infusing to. If we're giving the Lasix, I would go into the kidney function, talking about potassium, how the labs are doing. I would go more in depth and talk about more things, right? Especially if it comes to like labs and kidney function and all that, especially when they're more sick. But so now, if a patient, if I'm giving a report to an ER nurse or someone that perhaps just doesn't want a full-on report, it would be much more shorter, but still including all of the essentials, right? So it would just be, this is a 49-year-old female, doje, came to the ED for chest pain and shortness of breath for 1 week. Patient is admitted to tele for CHF exacerbation. Patient has a history of diabetes, high blood pressure, hypothyroid, and meth use in the past. No allergies. Bilateral 18 gauges to the ACs, and is currently on 2 liters nasal cannula with vital signs stable, and just pending an echo. So I would just keep it simple, just like that, right? And you're gonna figure out that a lot of your OG ER nurses and just a lot of the OG nurses overall, just want to keep it basic. So it'll take some time to figure out who likes what. But in the beginning, I want you to get used to giving very, very thorough reports. But don't just rant though. Don't just go talking about this happened and this. And no, just give the essentials like how we talked about. Give them thorough and go from there, right? But don't just rant and talk about random things that don't have any use for the oncoming nurse, right? Because they're coming in, they want to get a report and then start going with their day, right? So just stay concise, but be thorough with your reports. So, and then at the end of the day, just take a deep breath and know that it's going to be okay. And the more you do it, the easier it's going to be for you, right? So remember, just go with the flow, give thorough reports, and little by little, you're going to figure out who wants what. And don't worry if you miss something. That's why they're supposed to ask questions at the end if you perhaps miss something, right? Do your best to give side reports. That is something super important. Give bedside reports so that it is clear to your patient that you are leaving and someone else is taking over and assuming care. And it's also very important to give bedside report because anything can happen at any time. And if it happens between you giving report and the oncoming nurse going into the room, they may blame it on you. So it's very important for you to give report. For example, if you have a neuro patient who requires neuro assessment, you should do them together. The first one, so that you're leaving, handing off the patient to the other nurse, giving the report and the assessment, so that you're on the same page as far as like where the patient stands, just in case so that when nothing changes, right, and you're on the same page. And then some nurses on their nursing notes will write, report was given to so and so. And I have coworkers who will add also like report was given to so-and-so, questions and concerns were addressed, no acute change to patient status. They do this because of like a CYA type of thing. They want to cover themselves because they gave report, cover the bases, they answered all questions, and they gave a better report and did their own assessments, and nothing changed with the patient, right? And then at the end, it's a 24-hour facility. Let the staff go, right? Especially if you're coming on and you're getting a report. If something was amiss, don't make a big deal out of it. It's again 24-hour facility. You would expect the same type of respect. You had a long shift, 12 hours. You want to go home. Maybe you missed something. It's okay. They can continue the care, right? So don't be one of those people. So now with the question of the day, let's go into it. So what is the electrolyte that we monitor closely when a patient is on an insulin drip? Again, so what is the electrolyte that we monitor closely when a patient is on an insulin drip? Do you know the answer? If you don't, at the bottom of the description, the answer will be there for you. And then if you guys want to talk about it, we can in another video, but super simple. The answer will be at the bottom of the description text. And then thank you for your time today. If you enjoyed and learned something from the content today, I would really appreciate a like and a follow. Also, below in the description as well, I've listed my favorite ER nursing books that I've read that are extremely beneficial, because some of them I've read like 3 or 4 times already, and like I feel like every time I go back to read them, I learn something new or something just makes more sense from like why we do certain things at work, right? And then besides nursing books, I've also like put links to supplies that I use and supplies that I see a lot of my coworkers use. Maybe those are beneficial if you want to check out. But for sure, some of those books are amazing. Let's see. And then, as always, everyone, teamwork in the ER makes the dream work. And here at Emergency Chaos, we are proactive and not reactive. Thanks, guys.